Hello, and we welcome you to our fourth Thoracic Surgery Clinics podcast. Thoracic Surgery Clinics is a quarterly publication consisting of review articles devoted to a central topic important to general thoracic surgeons. The series and the podcast can be found at www.thoracic.theclinics.com. I'm John Vasallo, the managing editor for the series here at Elsevier, and for this fourth podcast, we will be discussing the November 2022 issue on esophageal cancer. Managing esophageal cancer requires thoughtful preoperative planning, technical oncologic resection, creativity in reconstruction, and meticulous postoperative care. Here to discuss articles from this issue are the guest editors, Dr. Elena Elimova, Assistant Professor in the Department of Medicine at the University of Toronto, and Dr. Jonathan Young, Assistant Professor in the Division of Thoracic Surgery at the University of Toronto in Toronto, Canada. Leading the discussion will be our consulting editor of Thoracic Surgery Clinics, Dr. Virginia Lytle. Welcome to all three of you, and over to you, Dr. Lytle.
Thank you very much, Dr. Elimova and Dr. Young, for joining us today to review your excellent compendium of management of esophageal cancer. Basically it's all like diagnosis, workup to management with targeted therapy, immunotherapy, and surgical resection. So I really appreciate you taking the time to put this together, and I hope everyone will enjoy it when they receive it in the mail. We could have discussed many of wonderful contributions from the authors you invited, but I have some questions for the two of you about several select topics from the issue. Before we get started with those, however, I'd like to ask each of you how you got interested in an academic and clinical focus on esophageal cancer. Now, I know, John, you do more than just esophageal cancer. I don't know how you do it because you do transplant too, and that's not for the esophagus, of course. I'm very impressed both of your talents and have enjoyed working with you and collaborating with you also at the Toronto esophageal meetings that Dr. Gail Darling had put together. May I start with you, John? How did you get an interest in esophageal cancer?
Thanks very much for the question. And to be perfectly honest, I didn't actually start my training with a strong focus on esophageal cancer. Like you mentioned, it was mostly in lung transplantation, and that remains sort of an important part of my practice. But when I joined the faculty, there was a real need for an additional esophageal surgeon in the group. And also, as you know, I was really fortunate to train with and then become a partner of Dr. Gail Darling, who's really a master esophageal surgeon. The more I did, the more I liked it. I became attracted to the field because you have to master many different operations for the esophagus. This is not just one. You could do anything from like a minimally invasive Ivor Lewis, which is our bread and butter. But you also have to know the three-hole, and you have to know a transhiatal. You have to know a thoracoabdominal, reconstruct the stomach, which is our usual, but you all still have to know the colon or the supercharged jejunum. It was really technically challenging, and we had to really tailor all of these potential operations to a particular patient's tumor. But more importantly, you have to really be a whole doctor. You have to really tailor these operations to the particular patient as well. And, there's lots of pre- and post-operative care of these patients, and I also think that not enough thoracic surgeons really dedicate themselves to this. I think most of us go into the field to operate on lungs, at least to start, or maybe I shouldn't speak for everyone, but at least for me. But as you get these opportunities to do esophageal cancer, I think it becomes very rewarding when you see patients do very well and get on with their lives. I'm also appointed as a surgeon scientist. So, when I saw the bad outcomes, it was really easy decision to kind of focus my lab on esophageal cancer, and they developed that academic interest as well, of getting with Gail's support and push, we developed organoids, and Elena and I are working on this. This is how I know Elena very well, trying to personalize the care of esophageal cancer patients using organoids. And I think this work is very exciting. I think there's just lots of opportunity in this field, and it's not maybe initially obvious for young thoracic surgical trainees, but it's extremely rewarding when you finally do these operations.
Great. And we all appreciate your contributions to the field, and I look forward to hearing more about your translational and basic science research in this area. So, Elena, how did you get interested in treating esophageal cancer? Because it can be emotionally draining, especially as a medical oncologist, but now it may be an exciting time as well, as we're seeing with lung cancer.
So I have a couple of answers. For me, it's actually a little personal because I have a lot of people in my family who are diagnosed with this cancer. So that's probably where I started. So a little bit different. As I was going through my training in GI medical oncology and in medical oncology, I kept seeing all these advances in breast, in prostate, in lung. But in GI, which is what I was really passionate about, there had not been a lot of advances, and in gastroesophageal, there really were no advances for quite a while. For me, I think I've always been the type of person to like to pick something of an underdog. And I thought, well, if all of these other fields had advanced, it was going to be our turn soon. So that's why I became interested in gastroesophageal cancer research. And then as I was training, as I was seeing patients, I also just loved the patient population. When you work with some of these patients and when you treat them, you realize how brave they are. They're so sick, but, they don't complain. And the way they approach their lives and how brave they are is just pretty amazing. And I think it's taught me a lot of lessons for how I approach things in my life. And that's why I do this. That's why I love it.
Well, we appreciate your contributions to the field too, and I completely agree. And there's so many areas we could be discussing, and there have been interventional advances over the past, 10 to 15 years with endoscopic resections for superficial cancers, and now application of immunotherapy. So beyond the actual interventional procedures, there's just so many places we can go, and so many things we can discuss. But let me start with the contribution you invited Doctors Audrey Jajowski and Daphne Elliott. They are pathologists, and you asked them to write about esophageal cancer genetics and clinical translation. So the two of them remind us of the challenges managing esophageal cancer, in particular given the genetic heterogeneity, not only between the histologic types, but also within adenocarcinoma and squamous cell, the two predominant types. We have seen this also with our collaborative screening study trying to detect malignancy in Barrett's patients using the esophacap or cytosponge type of device, and realizing it's very, very difficult given the genetic heterogeneity. This is with regards to biomarker testing. So biomarker testing has become routine for multiple solid tumors, including lung cancer, of course. Considering that esophageal adeno and squamous are distinct entities, please share with the listeners who, this is always an area that's pretty challenging, I hate to say, for surgeons to keep up with all this targeted therapy, biomarkers, because it's just such a rapidly evolving arena. But can you share with the listeners what the role of biomarker testing is at time of diagnosis and how it should be selected by clinical stage and by histologic type?
In terms of esophageal adenocarcinoma, there are really three markers we test for. And I think John knows this because whenever we discuss the cases in tumor board, we really drill it into our fellows and the surgeons who can kind of initiate this testing before these patients even come to us. So three things I want to know. I want to know mismatch repair status. I want to know HER2 status. And I want to know CPS now. So combined positive score for PD-L1. And so you might ask me, in which patients do I want to know this? And I would say I want to know it regardless of stage, because however you look at it, the majority of patients, even with a localized disease, will eventually have recurrences. I think there is some good post hoc analysis that show us that even with the adjuvant data, for example, combined positive score can help us predict who is likely to respond. So I think having these biomarkers is helpful to us as medical oncologists. So in terms of mismatch repair, I know it's rare in esophagus, but I think it really can help us direct therapy, right? MSI high cancers, there's mounting evidence that these patients do not benefit as much from chemotherapy, at least in retrospective studies. And so should we approach in the localized setting these patients differently? In terms of HER2, of course, that would help us with HER2-directed therapies, not in the localized setting, but in metastatic disease. And then in terms of combined positive score, even if you look at our recently published adjuvant study, Checkmate 577, in a post hoc analysis, we did show that the patients with a higher CPS were the ones who were most likely to benefit from adjuvant therapy. So even in localized disease, this is important to know. Of course, in metastatic disease, we have a good evidence that CPS helps us predict for response to immunotherapy in terms of overall survival. For squamous cell carcinomas, I think it becomes a little bit more complicated because various studies use various biomarkers. So I think CPS is useful, and that was shown in Keynote 590. But there's a second study, which is Checkmate 648, looking at the use of nivolumab along with chemotherapy. And here they used a different biomarker, this time called TPS, or tumor positivity. So I think what we don't know in squamous cell carcinoma exactly is what marker should we use? Should we use CPS or TPS? I think both seem to be useful. In Canada, we face challenges in that the testing is not yet funded. So we may soon be losing access to CPS and TPS testing. So that's an issue we face in Canada.
Well, that's interesting in the sense that I'm sure some people are willing to pay it out of pocket. Can they do that in Canada? And so then that just contributes to disparities in management of esophageal cancer?
I think you bring up a very good point. They can. We can still obtain it for foundation medicine. I think for me, it's troubling to be losing access to testing that I think is very important for patient care. For me, it's more about advocating appropriately to our governments to ensure that this is funded in Canada so that we don't fall behind other countries. For example, in Europe, the use of immunotherapy is linked to CPS testing. So in the first line setting in Europe, patients only who have CPS greater than or equal to 5 would have immunotherapy added to chemotherapy in the frontline setting. I think it should be for everyone. I think in the United States, from what I hear from my colleagues, it is done in everyone. And so I hope that we will continue to do it for everyone in Canada as well.
As a basic principle, when we're trying to think about who to invite for this issue, we wanted to not get the usual suspect, especially with my interest in esophageal cancer genetics, really get someone who had some experience with esophageal cancer genomics. And, Dr. Fels-Elliott worked with Rebecca Fitzgerald, who has contributed a large body of knowledge into esophageal cancer genomics. And I wanted her to really highlight these things to surgeons in a relatively easy to digest manner. And I think she's done a good job in this chapter. Many clinical studies still combine the two histologies, adenocarcinoma and squamous cell carcinoma. I think one major goal of this chapter is just to have her show, how distinct the two tumors are molecularly. And they may need to do that for numbers or just to be able to, study esophageal cancer as a whole with subgroup analyses, but it's important for the readership of these papers to know these are basically two different diseases they're looking at. And I think this chapter does summarize some of the genetics quite nicely.
Yeah, I think more and more of those who care for esophageal cancer are appreciating the differences in the two types. But at Foregut, we're trying to make that distinction, adenocarcinoma and then squamous separately. But it does take a little while to convert people, but you guys are working on it, so that's good. So that was a good segue into the contribution by Drs. Yang and Sloan Kettering. They wrote about immune checkpoint blockade and targeted therapies. So Elena, would you be able to comment a little bit on immunotherapy, TKIs and other targeted therapies, and how they've really impacted survival rates for lung cancer? We've seen about 4 to 5% increase to 5-year overall survival from lung cancer, and obviously lung cancer screening has contributed a bit to that too. But regardless, it's making the field of medical oncology and surgical oncology so exciting. So for esophageal cancer, chemotherapy and targeted therapies are used for advanced esophageal cancer. But as surgeons, we're caring for patients in the multimodality setting. So we also like to think about the role of these in the neoadjuvant setting. So can you comment on the current immunotherapy trials for localized, and I'm going to throw gastric in here too, for localized esophagogastric and squamous cell carcinomas, and which do you think hold the most promise for continuing into practice?
I'm happy to do that. I think that we already have good evidence that immunotherapy does help a certain subpopulation of patients. So just a reminder for everyone of Checkmate 577. So in that study, unfortunately, we included both adenocarcinoma and squamous cell carcinoma patients. I think, as John has mentioned, we will move away from that in the future. But these are patients that were treated with chemoradiation, followed by surgery. And then those patients that didn't have pathologic complete response were randomized to nivolumab or placebo. And what we found was that the disease-free survival was doubled, 22 versus 11 months. And that was of course, statistically significant. We don't know if there's an overall survival benefit. We're still waiting for overall survival to read out. But to me, it's a good sign that it hasn't read out yet, because it implies that we haven't had enough events for overall survival to read out yet. So to me, that's a good thing. In terms of the patients who benefit the most, I sort of mentioned a post hoc analysis. When we looked at outcomes by CPS, we found that the patients who benefited the most were patients with a CPS score greater than or equal to 5. And I just want to point out that squamous cell carcinoma patients, although they made a minority of the patients in this trial, benefited more than adenocarcinoma patients. So that study already sets up the use of immunotherapy in the post-chemo radiation and surgery setting. Now, you've asked me about ongoing trials, and there are a few important ones. There's the Dante trial, which was recently presented at ASCO by Dr. Albetran, and it looked at using FLOT combined with atezolizumab. Now, he was able to show that this combination is safe. So FLOT atezo, surgery, and then FLOT atezo. We don't know if there will be a progression-free survival or overall survival benefit. I think that remains to be sort of shown. The second study, which will support the results of the Dante trial, is the Matterhorn trial. This is a study which is completed accrual. It looks at using preoperative FLOT plus durva surgery and then FLOT plus durva. Both of these studies are trying to answer an important question. We know that some people use FLOT, some people use chemoradiation. We know in the setting where we use chemoradiation, immunotherapy helps. I think the next most important question to answer is, in the setting where we're using chemotherapy, does immunotherapy help as well? So I think those are two important studies. For me, what's also extremely intriguing are a number of neoadjuvant studies which are now ongoing in the MSI high setting. First of these studies was presented at GI ASCO. And I think what was really impressive to me about that study is when they took patients with MSI high disease, they gave them immunotherapy alone. In this case, it was a PD-1 and a CTLA-4 drug. The number of people that achieved pathologic complete responses was extremely high. Number one, it's an extremely promising treatment in MSI high disease. I think the second thing is it might beg the question of, in certain groups of patients, could we even get away from doing surgery? Because, we've always been asking those questions, and patients certainly ask us those questions. The last sort of group of studies that I think are important, we know that certain centers use definitive chemoradiation for treatment of squamous cell carcinoma patients. There's a whole group of studies now. This is a small group of patients that are being included in these studies, are looking at whether the addition of some type of immunotherapy that could either be an anti-PD-1 or a TIGIT plus PD-1 would be helpful following definitive chemoradiation in improving outcomes for patients. So I think this group of studies will also be important, but of course will impact a smaller number of patients.
So as we know with clinical trials, unfortunately, many of them get shut down early because of lack of accrual. And with esophageal cancer, considering the number of cases, about 20,000 a year, at least in the United States, that must be a big challenge, I would think, to enrolling these folks in clinical trials. Are some of them more likely to be able to complete their accrual, some of the trials that you just mentioned, and which ones?
So Matterhorn has completed accrual. We're just waiting for the data to read out now. Groups of patients where we're doing definitive chemoradiation and then giving, for example, immunotherapy thereafter, those are tiny groups of patients. There are actually 3 competing studies in that setting. I am concerned about the ability of those studies to enroll. I know in Canada, the majority of those studies actually did not open. I also know that in many centers in the United States, those studies also did not open. So that's where I have concern. For MSI high cancers, I actually think those studies will be done because there's a lot of interest in doing those studies. And I think the way that those studies will be done is through cooperative groups or intergroups. And I think that's the only way you can do studies in a small subpopulation of patients.
And perhaps collaborating more actively with our international colleagues as well. With the changing paradigm management of superficial adeno and Barrett's, thoracic surgeons work particularly closely with our interventional endoscopists, especially if the surgeons are not carrying out the endoscopic resections, ablations, and stentings, etc. themselves. You asked Dr. Dobashi and co-authors to write about endoscopic management of esophageal cancer. So there are some controversial areas in this arena, and one is the role of stenting for palliation of malignant dysphagia. So can you share with us your thoughts on stenting in that setting, the pros and the cons, and whether you guys do it for palliation?
Again, following the theme of trying to invite experts from their own fields for this issue, we invited these interventional endoscopists to talk about stenting. So I do stenting, but I save it really for palliation only. I mean, as surgeons, I'm sure we've all seen the poor guy, the newly diagnosed locally advanced EAC that just gets stented, and then they get sent to us for treatment. And now, you're stuck. You have a guy who has resectable esophageal cancer, but now has a stent in place, making chemoradiation more difficult, more scarring, making your operation more difficult. You then go in and try to pluck the stent out, but most likely they put a partially covered stent in, so you're risking perforation, in which case would preclude them from induction. So, a stent that's placed at the wrong time can be very detrimental to the patient. And so, I basically save stenting for when additional treatments are unlikely to further shrink the tumor. I mean, even in the metastatic setting, oftentimes, again, I mean, I'm sure Elena sees this, they stent a malignant patient and then she gives them chemo, which works well. And then the stent's in their stomach. And then when it finally grows back and ultimately fails chemotherapy, you're again kind of stuck with the stent in the stomach and not much options. So again, I save stenting for when additional treatments are unlikely to shrink the tumor and there's significant dysphagia. Clearly, there are risks there's pain as it opens and sometimes pain that continues. Perforation is always a risk, but you hope that the stent itself kind of contains the perforations, palliation anyways. And for the GE junction tumors, there's higher risk of increased reflux and regurgitation, of course. And for mid-esophageal tumors, if you don't place the stent, low enough, right away from from the upper esophageal sphincter, they might feel the stent. It's all pros and cons. I think for people who have been severely dysphagic for some time, it's still a very welcome relief from that. I can't say that stents are not useful. I just think you have to be very careful in when you utilize them.
Yeah. So you'd recommend completing your staging before considering placing a stent and using it only for palliating and in the advanced setting with the option of, radiation, chemoradiation to palliate as well. So.
Yeah. And you can always use chemoradiation to palliate. And when that fails, stent them.
Yeah. Endoscopic mucosal resection and subsequent ablation are now standards of care for treating high-grade dysplasia and superficial tumors confined to the mucosa. Submucosal resection, of course, is becoming more available depending on the skill set of your interventional or thoracic surgeons, interventional endoscopists or thoracic surgeons. So can you remind our audience which lesions is it appropriate to treat with submucosal resection? Because there are some characteristics about the tumor that say you should just really send them for definitive treatment with an upfront esophagectomy.
Of course, we can do a lot of things, but when should you do it? And that becomes the question. It's just because you can, should you? I think submucosal resection is one of those. As you know, it all comes back down to the risk of lymph node metastases, because any local therapy will fail. There's a very rich lymphatic supply in submucosa, and therefore just touching the submucosa is a high risk for lymph node metastases. I think, for T1A outside of submucosa, it's maybe 5%, depending on what you read. And in T1B, once it's into the submucosa, some studies have shown even up to 50% lymph node metastasis rates. I personally find it a bit high from my experience, but that's what the study have shown. And, again, you have to consider patient factors and then, of course, tumor factors. So there's been attempts to stratify this T1B population. First, it was relative depth, the top third, but that comes to be a bit difficult to know, and you maybe didn't get the whole thing on the EMR. So then there was looking at absolute depth, 200 microns or whatnot, to see whether or not there's a risk that actually correlates with the risk of lymph node metastases. Of course, there's the tumor characteristics. Is there lymphovascular invasion? Is it a high grade? And all of these things kind of come into some kind of calculation where you have to decide, is it worth it for the patient undergoing esophagectomy with its side effects and complication rates? Or is it better to do a local resection with, of course, risks of distant metastases, nodal metastases, but lower up front? So you also have to look at the patient factors. Someone who's 85, probably EMR or ESD is probably a good outcome. In a 40-year-old, you may say, okay, well, esophagectomy is probably better. But, that 40-year-old may actually push back and say, well, maybe I'll take the risk and just want a local therapy and have good outcome. And if I don't get nodal metastases, I may get to keep my esophagus. So it's not always so simple to, make these decisions. It's part of it is detailed counseling of the patient to make sure they understand. But if they understand and the tumor characteristics are favorable, and you've done all your other tests. Not to say that PET is very sensitive for microscopic disease, but you've done all your other tests and it doesn't show lymphometastasis. Maybe it is something that can be done locally.
And also that reminds us of the value of shared decision making, right? You had to incorporate the patient's wishes and views and values, et cetera. And shared decision making also is important from a multidisciplinary standpoint. And given that you guys are really leaders in the esophageal cancer arena, I suspect you have a very well-organized multidisciplinary conference, or like a high-risk GI conference that involves, I would like to hope, interventional endoscopy, medical oncology, pathology, radiology, and surgeons. Can you just let our audience know what your setup is? Because I know it's really not a universal thing that we see, at least in the States.
We meet weekly. We learn a lot from each other. We meet routinely with the radiologist who leads the review of all of the available imaging. We have a GI pathologist who specializes in the esophageal gastric, can help, of course, review all of these factors in EMR specimens. We make sure we pin it, look at the deep margin. After COVID, it's all on video conferencing platforms, so we can share our screen and take a look at the actual slides themselves. Of course, we have multiple medical oncologists, multiple radiation oncologists, multiple surgeons, so we can all give our opinions. And, we all come from different backgrounds, different trainings. And I think that really helps for these difficult cases, because everyone has their own biases, and we can discuss this. We all work together very well. I think many of us are friends outside of the tumor board as well. So I think that helps a lot in the discussion and generating very constructive feedback about each patient. We don't have an interventional endoscopist at our tumor board. I think that we invite them as necessary. Part of it is we have one at our institution, but we have many at a different institution, and so we involve them where necessary.
I think it's really useful because, as you've mentioned, even when we're talking about stent, we will often discuss these cases before a stent is placed. And I think that's useful because we get to hear each of our concerns, for example, before we decide to proceed with it. I also think that at least at our institution, the majority of the biopsies of these tumors, John, would be done by you guys. Stenting can also be done by you guys for palliation. So I still think that we have all of the disciplines we need to make our decisions. And generally, we try to make the decision as a team, taking into consideration, the patient's comorbidities and what the best plan is for that individual patient.
So this sounds like a thoracic surgeon-led program for management of the esophageal cancer, yet the opportunity to provide a forum for folks to bring their cases and to discuss it. The person who's kind of in charge, like, who does the patient see as the newly diagnosed esophageal cancer? Are they all referred to you? Like, what is your process?
It's shared. I think for all comers, if they don't have tissue diagnosis, come to the surgeon first, at least in Canada. So that's very helpful, I think, for us because it allows us to make the diagnosis and to accurately stage them and to get it into our esophageal family very quickly. Once we have tissue, then we know. I mean, we've staged them and we can decide if this patient is potentially resectable or potentially resectable after induction, that kind of thing. We try to present every operable case at our tumor board. I don't think we could do every metastatic case at our tumor board, unfortunately. But at least for any resectable case, we can negotiate the different, pros and cons. Of course, I recently referred someone to Elena who, had peripheral neuropathy. And, of course, that's a big problem with chemotherapy. And that gave her quite the challenge, I think, to pick something. Yet, I felt that he was resectable. And again, patient desires and things need to be taken into account for difficult decisions. And again, that's where having multiple oncologists and surgeons there to discuss the cases is very helpful.
All right, moving on to another surgical question. So we have talked about biological differences between adeno and squames, and you asked Drs. Xu and co-authors from Taipei to write about lymph node dissection for squamous cell carcinoma. So please remind our listeners, John, on the importance of adequate lymphadenectomy for squames in particular, and what the optimal dissection is based on tumor location.
That's the million-dollar question. What is the optimal dissection? We asked Dr. Su to kind of discuss this, to give a really different viewpoint because he actually practices out in the East. I think, at least here we often think of SCC mostly as a disease of the East and EAC as adenocarcinoma as a disease of the West. But of course, we do see SCC here, but don't have the same volume as they do out East. And at least in general, I think I can say we don't do routine bilateral recurrent lymph node dissection or definitely not for EAC and likely not for SCC here in North America. And yet they do that routinely in the Orient. And so we asked, Dr. Su and colleagues to review the data. There's not a clear answer. Some studies have shown survival benefit with 3-field dissection, Turkey here, among others, and out many studies out in the East. But there's differences in the findings. Some will say that there's a survival difference, and some will say there isn't. The controversy, of course, also includes, lymph node dissection. Is it prognostic or therapeutic? If you look at that large Swedish trial, they showed no difference in lymph node dissection of any kind. And again, that was a bit surprising. For us doing adenocarcinomas, I think a 2-field dissection is the minimum. And I think that, getting at least 18 lymph nodes, I think is the minimum. But the question really is doing more better? And that's a very difficult question to answer based on the data we have. There's tables 1 and 2 in that article, which summarizes both recurrent lymph node dissection and cervical lymphadenopathy data, along with recurrent laryngeal nerve palsy rates, which, aren't insignificant. We look at them and then we look at if there's survival benefit. It's mostly not. There's obviously some large trials that show some benefits, so the controversy continues, but many of them do not. And then you also have to be practical. I think if surgeons in the East are routinely doing these dissections and they show some really cool ways of using ICG to find the nodes, etc., and we are not, the relative inexperience of the North American surgeon will likely increase the recurrent laryngeal nerve palsy rate even higher or cause even more morbidity. And I'm not sure the data is clear enough now to show that we have to do a 3-field dissection or recurrent lymph node dissection routinely and have a survival benefit. It's a hard question to answer. I think that we should know the technique as North American surgeons, and I think with ICG and all these things coming out, we should know it, we should learn it, and then we can do the studies properly so that our inexperience isn't a factor.
We are making some improvements similar to the advances we saw with breast cancer, years ago. No more radical mastectomies, and really just the benefits of systemic therapy. And I think now there's going to be even less of a role probably for these more radical esophagectomies, given some of the benefits of systemic therapy and the advances. Elena, could you tell us, is there a brighter light at the end of the tunnel for patients with esophageal cancer? And if so, which therapies do you think will have the biggest impact?
I think esophagus and gastroesophageal cancer in general is going the way of lung cancer with molecular profiling and subtyping. As that chapter that we discussed earlier mentions, gastroesophageal cancers are diseases of amplifications, not necessarily of mutations. But some of the things that we have looked at and found to be promising, for which trials are waiting to read out, are things like Claudin in the first line. There's a lot of new HER2-targeted therapies that I think and hope might be better than Herceptin, than what we have now. Trastuzumab deruxtecan is one. Zanidatamab is another very promising one. There are many coming. And so John knows we're very involved with clinical trials in this setting. And then FGFR is also an important marker. And there is a study that will be reading out there as well. So I think the way I envision the treatment of esophagus cancer, I hope in the next, let's say, 5-10 years, is we would have all of these biomarkers tested. How we will pick which biomarker is most important, I don't know yet. So let's see. But I think it's a great time. And I do think there are going to be new systemic treatment options, which of course make me very excited.
It does get a little old just giving the same chemo regimen, I'm sure, to people and having no other options. So yeah, you definitely have seen that improvement and excitement in your field. John, since this is a surgical clinics, maybe you can just add, where are we going? I mean, robotic esophagectomies, endoscopic resections. Can you add anything else from a technical standpoint that may be shining some light at the end of the tunnel?
It's not going to be bigger surgery. I think, like you earlier mentioned, I think the day of trying to cut more out to get the cancer better controlled is not going to, I think what, like Elena says, all of these systemic therapies will play that role. I think part of it is going to be doing less invasive and more tolerable surgery. Minimally invasive, definitely. Robotic, probably. Maybe, that's the argument there is better lymph node dissection. And, maybe that will help to an extent. I think, how do we make the post-operative outcomes of these patients better? I think we can do the best Ivor Lewis esophagectomy or whatever, and the conduit doesn't empty, in some patients. Maybe they were diabetic, maybe they, maybe it's a vagal thing, I don't know. And in that small population, they never get back to normal, really. They never can swallow properly. They have a lot of trouble. How do you improve that technically? Obviously there's a lot of controversy of the narrowness of the conduit and how high you pull it up. Is it straight? Is it redundant? But how do you standardize this, and how do you object? It's very difficult to study if you can't, get objective measurements. And of course, every surgeon does things slightly differently, and we're down to even where you put your ports. And this is maybe a bit too optimistic, but now that maybe survival in the immediate post-op period is no longer the 50% survival. Now that patients are surviving their esophagectomy, how can we as a field improve the function of the conduits and the reflux and the long-term post-operative morbidity of these patients? I think that's probably the next surgical kind of frontier.
Yeah, that's a good reminder for the young investigators out there who are looking for things to study. There is some research you can still do to answer technical questions as well. Well, I thank you both for joining. This is a fantastic issue, and I hope our readership will enjoy it.
Thank you for joining us for our fourth Thoracic Surgery Clinics podcast devoted to the November 2022 issue on esophageal cancer, Volume 32, Number 4. This series is available for individual print or online subscriptions. Visit www.thoracic.theclinics.com to subscribe. This series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter @Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Amazon Music, Spotify, or Stitcher. Thanks for listening.